it's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
So, look, tonight we'll discuss a little bit about polymyalgia rheumatica and what it is. And then kind of delve a bit more, as Robyn said, into how we treat it and some of the one of the main associated conditions that can occur in people who have polymyalgia rheumatica. And I just want to start off essentially just kind of breaking down the name of the diagnosis, because certainly I know people who are very familiar with, I guess, Latin and all those other sort of old school languages, they'll think polymyalgia means multiple muscles. And then the rheumatica, I don't know where that fits in. I never did Latin, but a lot of people think it tends to be more of a muscle problem, but it's actually an inflammatory joint disease. It's an autoimmune condition that affects the big joints, so shoulders and or hips. Now, a lot of people describe predominantly pain and stiffness in the shoulders and or hips, and usually it's with inactivity. So, for example, when they first wake up in the morning, they find it really difficult to get going, and as they get going, they get moving, they feel a lot better. Sometimes they'll say, you know, the stiffness has been lasting about half an hour, and then as I start moving, it kind of gets better. For some people, it's a lot longer. And then there's a group of people who tend to report not so much pain in the joints themselves, but an ache in their upper arms or an ache in their thighs, and difficulty sort of reaching up to get something from a cupboard, or putting clothing on the line, or standing up from a seated position and they have to sort of push themselves using their arms, which can sometimes be difficult because their shoulders or upper arms are also affected. So generally, those are the kind of symptoms that patients with polymyalgia rheumatica present with. How we diagnose it is actually really important, and there's a couple of things that I really want to focus on. I think the really important thing is to recognize that it is a condition that affects only the large joints. So as soon as we start to have symptoms like pain, stiffness, even swelling of smaller joints like the fingers, wrists, ankles, knees, and so forth, it's no longer polymyalgia rheumatica, and we have to think about something else that's causing this. And some of the other differentials or other conditions that can look like polymyalgia, because they're also inflammatory joint diseases, include rheumatoid arthritis, psoriatic arthritis, other kinds of joint diseases. And our role as a rheumatologist is to work out what is the pattern of joints that are involved, and are there any other symptoms, such as a history of psoriasis, or, you know, a strong family history of rheumatoid arthritis and so forth, that would point to one of those other disease diagnoses other than polymyalgia rheumatica. The other important thing is when we have a history that's quite typical for inflammation in the joints, we also then, obviously we examine patients and see which joints are tender and which are swollen, and if there's any limitation or weakness in the arms and thighs. But once we've done all of that, some of the more helpful blood tests that we look at are the markers of inflammation. So those are ESR and CRP. Those are very commonly done blood tests to check for inflammation, and they're generally elevated. For some people, they might not necessarily be very high, and for some people, they might be only one of them is elevated, the other one not so much. But in general, both of them will be elevated at some point. Another really important thing to keep in mind is that with patients who have large joint inflammatory symptoms, we check for the antibodies for rheumatoid arthritis. So those are rheumatoid factor and anti-CCP antibodies. And the reason we do that is because, as I mentioned, sometimes people can have initially small joint involvement, and so that automatically excludes polymyalgia and makes it more likely another diagnosis, such as rheumatoid arthritis. But sometimes people, particularly older people, will have only upper arm and thigh pain, suggestive of polymyalgia, but as time goes on, they actually end up developing or manifesting, not so much manifesting, but I guess declaring themselves more as a rheumatoid picture with smaller joint involvement, or they don't respond to the classic dose of prednisolone that polymyalgia is very responsive to, and I'll get to that in a second. So it's really important that we work out from the beginning if those antibodies are positive, even if they do have large joint involvement only, then I would be calling it more rheumatoid arthritis from the beginning, and that has really important implications in terms of how we manage the condition moving forward. And again, I'll touch on that in a moment. Are there any questions at the moment, or I'll just pause there for a sec?
Thanks, Pauline. I'm just having a look at the chat. There's nothing there yet, so if anyone does have questions, please start popping them in. But I have a question to, I guess, get us started. When it comes to diagnosis and, I suppose, initial onset of symptoms, Pauline, is this a type of, I guess, condition where, you know, as soon as you start to feel that shoulder pain, we really need to get diagnosis quite quickly? You know, I'm sure people have pain and they go, oh, is this just, you know, niggles? I'm sure it'll be quite painful, but yeah, is this something that really needs to be diagnosed straight away? And like, as you said, you know, the potential that there's other conditions that, you know, you might be questioning.
Yeah, absolutely. I mean, I think whenever people have joint pain or they've got functional limitation in some way, they can't lift their arms, they can't carry on with their day as per normal, or they have difficulty doing that, it's really important to try to get to the bottom of it as soon as possible, because it's not just necessarily about the diagnosis, but it's about quality of life and functioning. And a lot of people will need to look after their loved ones or spouses or work and so forth. So, you know, the earlier the diagnosis, the better it is, because we can start to help essentially and get people functioning back to normal. Sometimes it's not that painful. I've seen a few patients who just report an ache, and so of course that would be understandable that they might have left this for a very long time, thinking, oh, you know, I used to play sport, or I was fixing something and I pulled, like I was hosing down the garage or whatever, and I pulled a muscle and I felt it in my shoulder. And so sometimes things can be dismissed because there's another, I guess, more reasonable or more common explanation for it. But I think the message is that if you have these symptoms that have been going on for some time, for some weeks, and what you would normally do to manage pain, like take Panadol, for example, or anti-inflammatories, if that's been permissible by your GP, who's obviously more familiar with your other medical problems, then and you're not responding, or you're trying to do some physiotherapy and it's just not really working, it's actually making things worse, then we need to kind of, I guess, stop and reevaluate the situation to work out, is there actually something going on? And is that something an inflammatory problem that's just being exacerbated initially by the overdoing of things?
Excellent. I don't know if this answers the question that's popped up in the chat here, but if someone has been already diagnosed with PMR, but then they've noticed there's pain in their knees, wrists, ankles, you know, what should they do? And my assumption is it's something you should be, you know, speaking to your rheumatologist about and having that ongoing conversation. But anything else that you can add to that, Pauline?
Yes. So definitely if there's already been a diagnosis made, and of course I'm not sure, I can see the chat there, I'm not sure what kind of pain your people are experiencing in other joints even after they've been diagnosed with polymyalgia. I think it's important to, if you're seeing a rheumatologist, which I'm assuming you would be if you've been diagnosed with PMR, it's really important that you go back to see them so that they can work out what is the nature of that pain, and is the nature of that pain inflammatory, which would therefore suggest that especially with smaller joint involvement, we need to rethink the diagnosis and work out, is this a polymyalgic onset of rheumatoid arthritis, which I sort of alluded to before. Because as I said, small joint involvement is not a polymyalgic problem.
All right. One more question before I let you move on. Good question here. Is the pain or problem on both sides of the body usually? And is it episodic?
So it can be on both sides. It can be asymmetrical, so it can affect one side or another initially. initially one side and then gradually can affect the other side. But most of the time, once patients have onset of symptoms, they tend to continue until treatment is started. So it's not like some other conditions where, for example, in rheumatoid or psoriatic arthritis, sometimes people can have, the onset of symptoms and then it just kind of goes away on its own for a short period of time and then they become symptomatic again. That's not as common in polymyalgia rheumatica.
Okay, great. We'll let you continue. After diagnosis, what happens?
So once we've made the diagnosis and, we've got inflammatory markers that are elevated, well, first of all, we've got typical inflammatory symptoms or a history that's suggestive of polymyalgia. There's no small joint involvement. There's raised inflammatory markers and negative antibodies for rheumatoid arthritis. Then it's we're more confident in making that diagnosis and then starting treatment. And the mainstay of treatment is prednisolone initially. And so prednisolone is a strong anti-inflammatory. So it kind of works like your Nurofen and Voltaren, but it's a lot stronger, right? So it's something that we use at a dose of 15 milligrams per day. And that generally is meant to completely settle down the symptoms within 24 hours. So the first thing that I would say then is if somebody does not respond to 15 milligrams per day and they have those classic sort of PMR symptoms and the joints, the large joints that are involved, then I would rethink that diagnosis because it should completely settle down, right? So part of that is a bit of a diagnostic test, but I tend to not use prednisolone as a diagnostic tool because of the side effects that can be associated with it. And also because it's such a strong anti-inflammatory that it can help with a number of different things. But I'll kind of touch on a little bit of that later on if we've got time. Generally, when people respond to the 15 milligrams of prednisone, we continue that for 1 month and then reduce it to 10 milligrams a day and continue that for 1 month. And then we start to reduce by 1 milligram per month. Now, that means essentially that people would potentially be on steroids for a total of about 10, 11 months, depending on how well they tolerate it. So if they don't start to have any side effects from it. And as we're weaning, if their symptoms don't continue to come back, which means that it's not as sensitive to the steroids, then again, we need to rethink whether or not polymyalgia is the correct diagnosis, or this is a polymyalgic onset of another inflammatory condition, usually rheumatoid arthritis. And in which case, we then need to think about starting alternative treatment that it works in the same way as prednisolone, which we call steroid-sparing medications, starting those sooner rather than later so that we're not continuing someone on steroids for a long time when we know that they're unlikely to come off. So if that is the case and we need to use other medications to substitute for prednisolone, I should say, the commonest drug that we use is methotrexate, but there are other options. So some rheumatologists will use leflunomide, but really it's a discussion between the individual patient and their rheumatologist. But I generally use methotrexate unless there's a particular reason why that's not an appropriate drug for the patient that I'm looking after. But it's important to know that these steroid-sparing medications take up to 3 months to take full effect. So it's not like we can just stop the prednisone as soon as somebody starts, for example, methotrexate, because we know that as soon as the prednisolone stops, there's no anti-inflammatory cover, and then it's almost like they're untreated until the methotrexate slowly builds up in their system. Once the steroids or other agents are started, then it's really important that we do blood tests every month to check a number of things. The first one is that they're not having any problems related to their bone marrow or kidney or liver function tests from being on these other medications and steroids. Of course, we assess patients on a regular basis to make sure that they're not having any side effects either. But the other thing that we monitor on the blood tests is the markers of inflammation, and it's really important to make sure that they actually normalize once they start steroids. Any questions there?
Pauline, when it comes to using steroids, and you've spoken about weaning off, roughly about by the 11 months or the end of the year, is that common, or is it also quite common to have people with PMR to stay on steroids for longer than that, and whether it's months or years because their body's not tolerating the low or no dose?
Yeah, so that's a good question. Sorry about that barking. That was eventually going to happen. That's a really good question. So because polymyalgia is very sensitive to steroids, and we start at 15, we do our 10, we reduce by 1 milligram a month, we should be getting patients off steroids by that 11-month period. So if someone is on a low dose of steroids because they just can't come off, and I've seen a few patients like this where they're just kind of, I guess, stuck on 5 milligrams or 4 milligrams or even 2 milligrams a day, then I guess I'm personally uncomfortable with that, just because there are long-term complications associated with steroids that are not just necessarily associated with a high dose, being on a high dose, but it's more of a cumulative effect. That means that the longer you're overall on steroids, the higher your risk of certain side effects, like your blood pressure going up, blood sugars going up, and developing diabetes, heart disease, putting on weight, bones becoming weak, and getting osteoporosis. So if somebody has difficulty coming off steroids, again, number one, I would be revisiting that diagnosis and wondering whether they've actually got another inflammatory joint disease, even if it's just affecting their large joints at that point, and considering putting them on a steroid-sparing medication sooner rather than later.
I have another question that I get from my patients quite a lot. So I thought maybe you could help answer this. I'm sure other people are thinking the same. So I get the concern when it comes to prednisone. And if within that first 11 months, some patients just really don't want to be on prednisone. You've started to list some of those side effects. And I get quite strong feelings from patients that they generally just don't want to go on it, they refuse. So is it that you don't go on prednisone and you're going to just be in a lot of potential pain, or is there any other option? As much as we know PMR is medical.
Yeah, so look, I mean, we of course, if patients have really strong reservations, despite having, I guess, that discussion between them and their rheumatologist about the pros and cons of being on steroids for that period of time and so forth, or even if they're quite happy to be on steroids, but they've got high blood pressure and diabetes and osteoporosis, all of those things, I'd be offering a steroid-sparing medication sooner rather than later, because at the end of the day, we know that we need to treat the inflammation. And if it's not going to be through steroids, then it has to be through something else that works like steroids, which are those steroid-sparing medications. So I have no reservations about starting somebody on methotrexate straight up if they've got concerns or they're extremely reluctant with going on to steroids. I think it's a completely different discussion if somebody doesn't want to go on steroids, but also doesn't want to go on those steroid-sparing medications, because then really the focus is going to be on how are we possibly going to control this inflammatory condition without any treatment at all. And of course, there's a role to some extent with healthy eating and an anti-inflammatory diet and exercise. But initially, when there's active inflammation, it's very difficult to get that under control with non-drug means.
Fantastic. Okay, there are a couple questions here, but they're not directly related, but I will save them towards the end. So let's continue so we can get through some more of your slides and onto exercise as well.
Sure. Is the slide progressing at all? Oops. Okay. So one of the things that I kind of alluded to at the beginning was polymyalgia rheumatica can be associated with a condition called giant cell arteritis. Now, they're completely different conditions. They're not even on the same spectrum of condition, but for whatever reason, there seems to be a bit of an association. So giant cell arteritis is an autoimmune inflammatory condition that affects the large blood vessels. So that's things like the aorta, the subclavian, the axillary, so the big arteries that kind of come off of the aorta, which is the big one that kind of runs in the middle of your body, essentially. and supplies everything else. And the main concern with this condition is that because it can affect the blood vessels that run off the big ones and supply blood to the eye, to the retina, if this is not recognized early and treated very, very quickly, then it can lead to blindness in one or both eyes. And often that can be irreversible. So that's kind of why we need to crack onto it very quickly. Now, in some patients, what usually happens is that patients will have polymyalgia rheumatica, for example, for many years, and then they potentially then years later can develop giant cell arteritis. It's not a given. It doesn't mean they will absolutely develop it down the track, but it is a risk that we have to counsel patients on, that this is something to watch out for. Sometimes, in a very small proportion of patients, they can have the onset of polymyalgic symptoms as well as giant cell arteritis symptoms. And I'll kind of get to that in a second. And in a very smaller proportion of patients, they just have the giant cell arteritis symptoms and they don't have any preceding or pre-existing symptoms of polymyalgia rheumatica at all. So that's just something to keep in mind, but it is an important diagnosis for us to watch out for, especially when we're seeing somebody with polymyalgia rheumatica. And certainly whenever I see patients and diagnose them with PMR, I always ask them whether they've ever had any headaches or new headaches, sort of either new headaches or headaches that are different to what they would normally get if they do have a tendency to get headaches. If they get pain in their jaw when they chew, and then when they stop chewing, it stops. And if they have tenderness of their scalp, so often if they're combing their hair or if they're scratching their scalp and they feel like a lot of tenderness, those are the main things to watch out for, to screen for from a symptom point of view. Obviously, if somebody says they have headaches and a bit of pain in the jaw when they chew, and they also then have like blurry vision, or there's like a curtain, a black curtain sort of that falls in front of their vision, that's a massive concern for us, because that's an ocular emergency essentially, because it suggests that there's eye involvement, which is what we're trying to avoid. Especially if it's happening in one eye, we want to get onto treatment as quickly as possible to prevent loss of vision in the other eye. So even if there's irreversible loss in one eye, the treatment is there to help prevent loss in the other eye. How we treat this is slightly similar, but very different in terms of comparing it to PMR. So the dose of prednisone that we need to use for this condition is very high. So it's 1 milligram per kilogram of body weight per day. Now, the maximum would be 60 kilos. So if somebody weighed 100 kilograms, that's not their, sort of main body weight. So I wouldn't be putting them on 100 milligrams per day of prednisolone, but the maximum would be about 60 milligrams per day. Once we start steroids, we have to urgently get the patient seen by an ophthalmologist, who will generally be very accommodating in doing a biopsy of the temporal artery. So that involves just doing a little cut, taking a bit of the artery out and sending that off to the pathology lab to be analyzed quickly to see if there's any features there histologically of polymyalgia rheumatica. And there's a couple of technical factors that we need to be really cautious about in terms of how this is done and in order to then interpret the result properly. And once the diagnosis comes back and is confirmed on biopsy, then we know how we're going to treat it. And usually that involves a very, very much slower weaning regime of prednisolone. And usually patients are on it for about 12 to almost 18 months. So it's a lot longer than polymyalgia rheumatica. But again, depending on the clinical situation, if patients have other medical problems that mean that they cannot be on such a high dose of steroids, for example, they've got diabetes and their sugars are all over the place, or their blood pressure is through the roof, or they've had a history of stomach ulcers or whatever it may be, then we need to introduce a steroid-sparing medication, again, sooner rather than later. And there's a number of different options. I won't go into that bit too much, but there are obviously ways of managing giant cell arteritis similar to polymyalgia rheumatica, but they are, the upshot is they are completely different conditions, but there seems to be an association with them. So we see people with PMR and we have to kind of screen and watch out for the development potentially of giant cell arteritis along their treatment course. That's it, unless anyone has any other questions.
Thank you, Pauline. I think that last few slides there about the giant cell arteritis is, it might be something completely new to you guys watching, and hopefully keeps that front of mind, right? To just watch out for some of those symptoms, the headaches, the blurred vision, the temporal pain. And it's something that you should definitely always bring up with your doctor and your rheumatologist, particularly, even though you're like, but that has nothing to do with my shoulders or my hips or my neck. Still extremely important. I'll throw one more question at you, Pauline, before I dive into exercise. This is a question, I suppose, about the polymyalgia rheumatica as a condition in itself. Is this something that can be cured as such, or is it something that goes into remission and then you don't hear about it for a while, and maybe there's that that risk of it recurring?
So it's I generally am a bit hesitant about saying cure for any autoimmune or inflammatory condition. Certainly what we aim to do with treatment is to get people into remission. And I know that that's a term that usually is associated with cancer, so it sounds a bit scary and it sounds a bit sort of life and death, but it just means, the condition is quiet. It's not active. It's not causing any symptoms, any functional problems. It's under control. And we can get into remission with polymyalgia rheumatica after that period of about 11 months or whatever it is, once we've weaned off steroids. The risk of it coming back is very low, but I never say never in rheumatology, and I never say never in medicine. So it's really important to know that, once people complete their course of steroids, after that period of time, they can stop. I generally see them about a month and then maybe 3 months after that with repeat blood tests to see whether their symptoms have come back or whether their inflammatory markers are starting to go back up, or whether they're starting to develop any other new symptoms that would suggest that maybe this was not polymyalgia to begin with. But once they're sort of, I guess, in the clear, they're pretty sweet, but we do keep checking for things. And I always tell patients, even after I've seen them 3 months after they've finished treatment, if anything changes, if anything new develops, you do have to get back in touch and let me know. And certainly I warn them about the symptoms of GCA that could potentially occur, so that they're also aware to flag that with me or their GP or whoever sooner rather than later.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events.